Big speech, you would take care of this now, right?
It's a critically important structure for both life and for speech. It is very deep in the tissues of the neck. The larynx is made up of a series of cartilages placed atop the trachea. The cricoid cartilage sits immediately on the trachea, and the thyroid cartilage articulates with the cricoid. The tiny arytenoid cartilages sit on the posterior cricoid cartilage. The vocal ligament of the vocal folds runs from the arytenoid to the thyroid cartilage. The lateral cricoarytenoid muscle closes or adducts the vocal folds, rocking them toward the midline. Phonation for speech is initiated by simultaneously starting airflow from the lungs and trachea and bringing the vocal folds closer together. When the folds move closer together, the air pressure between them drops, and the vocal folds are sucked into the airstream and are pulled closed. The air pressure beneath the folds blows them open, but they are pulled back together by elasticity and the negative pressure of the Bernoulli effect. This cycle is repeated over and over until the vocal folds are abducted or removed from midline. When you look at the vibrating vocal folds in cross-section from behind, notice that they open from the bottom to the top, and that they close from the bottom to the top. This is a critical contributor to the complex acoustical phenomenon of voice.
Okay, now the one that you wanted me to show, Joe?
It's on YouTube.
You didn't send her the link, Joe.
My Wi-Fi's not working.
So what do I look at?
If you do vocal box anatomy, it's one of the top ones.
Which one?
What one was it? Just look on my phone. It's like one of the top ones.
That one at the bottom. Is it the second one?
It might be.
It looks like it's looking down from the top.
The human voice system is like a musical instrument. At its center is a vibrating element that produces sound with varying tone and loudness. The vibrating element in the human voice is the vocal cords. When air is exhaled from the lungs and through the larynx, it causes the vocal cords to vibrate. During normal breathing, the vocal cords are held apart and no sound is produced. But when the moving cartilages are drawn together by muscles, a vibrating gap is formed that generates sound. The cartilages tilt to control vocal cord tension, and like the strings of a musical instrument, the greater the tension, the higher the pitch. The lower the tension, the lower the pitch. Loudness depends on how fast the air moves past the cords. When we yell, we have to push the air rapidly through our vocal cords. Speech is formed by a combination of tongue, mouth, and lips all working together to control the flow of air and sound from the vocal cords.
Yeah, so I'm going to show you those tongue positions and ask you what the letter is. Not.
Try that second one. That one's more.
We'll look at this one and then, wait, let me go back.
This is so uncomfortable.
Sorry. Oh, this isn't very loud.
The endoscopy is ready to commence.
Oh.
Here we have a view of the intranasal cavity. The uterus, the air we breathe. The endoscope is being passed through the nasal cavity to the posterior aspect. Please note the soft palate. A soft palate moves up and down with certain speech tasks. A baby bottle.
Baby bottle.
The endoscope will now be passed inferiorly where we will get our first glimpse of the voice box.
So your label tonsils would be right here.
Note the posterior pharyngeal wall squeezes
Looks like an
together
alien.
as the accelerates.
So that would be the uniform. Must be right here.
the voice box. The rhythms are what moves the vocal cords together as well as apart.
Wow, that's deep.
The strobe light will now be turned on. The strobe light allows us to visualize the vocal cord vibration. Note that as the pitch elevates, the true vocal cords become longer and thinner.
Thyroid
that
muscle.
before.
When the vocal cords are apart, we are able to breathe in and out. A voice is created when the vocal cords come together and start to vibrate very quickly.
She's doing all that with a camera in her throat.
Wow, that's crazy right now.
I think I'd be a little higher pitched than that with the camera in my throat.
Ears are being removed carefully.
Oh, carefully.
Now,
What do I get that?
So I have a question,
Yeah.
Professor.
Yeah.
When I was younger, I had what they called nodules on my vocal cords,
Uh-huh.
which they explained to
They
me
don't
as
go through your throat.
kind of like calluses. And what they said was happening is that my vocal cords were slamming into each other that caused calluses.
Wow.
So they had to actually burn them off with a laser.
Were you shrieking a lot?
I was coaching.
Okay.
I was a football coach, so I was always yelling and
Projecting it.
projecting a lot. Well, house full of 8 kids too. But, so those that were moving were the vocal cords that were
Right, the ligaments would have been within that. That was a mucous membrane covering over the vocalis muscle, and then the ligaments would have been, yeah. So the white, what you receive was mostly through the mucous membrane to the ligaments. Muscles are actually a little bit more lateral than that.
Okay, yeah, because I always wanted to know, because I didn't even do speech therapy
Yeah.
for all that, and my voice actually, because I was a receptionist at the time when I went back to work.
I wonder what it would
my
look like if
doctor
you
said my
did that
voice
to
was
Keaton and had him do the
higher
pterodactyl.
pitch, not as low.
There was about 12 years ago when I was teaching, one of my students had a son who had polyps on his vocal ligaments, which were thought to be caused by viruses. But as an infant, they didn't realize they were there until they kept growing and growing, and they practically closed off his airway. So he turned cyanotic, he rushed into the emergency room, and it was these polyps that were growing up like large blisters. And so they kept coming back. They thought it was a viral in cause. And so they would just, they would watch him, and his energy flagged, rather than waiting until he turned blue, they would just watch his energy level. And they could tell when he was getting more tired, and they would take him in and then cauterize him again. And it happened so frequently. He, of course, as a kid, baby toddler, was afraid of people in white coats and stuff. And so his parents would notify them, and they'd take their jacket, try to be in street clothes. To me, that just meant he'd be afraid of everybody in street clothes for a while. But they got lesser as he grew older, and they were hoping that he would eventually grow out of it. But you can imagine all the scarring that would have on his vocal ligaments. I'm not sure what condition that Julie Andrews, the singer-actress, had, but she eventually had sufficient amount of surgery that she no longer can sing anymore as a result of that. All right, so we're going to look at the trachea now. And so we are in our lower respiratory tract. We've always said the larynx would be the last or most distal region of our upper respiratory tract. So we're on page 22. And having had this up all morning, I'm assuming you have this image down. So the primary purpose of the trachea is to provide a connecting tube between the oral the laryngopharynx and the lungs, because it is also lined with pseudostratified pulmonary epithelium. That those goblet cells are going to secrete mucus, so it continues to try to remove particulate matter from the air. The finer the particulate matter, the farther down the respiratory pathway it will move when you breathe in. And so this is going to be found as a structure of the superior mediastinum. and the middle, because it's going to pass posterior to the heart. And then, kind of at the level of the left atrium, it's going to divide into our right and left primary bronchi. So we're seeing it span from here to here, all right? Now, as a structure of the air pathway below the larynx, if an individual has a blockage, if they, now my father-in-law was having to go into the hospital every 3 to 4 weeks with pneumonia. Pneumonia has multiple causes. I had bacterial pneumonia in January. His was aspiration pneumonia. He had difficulty swallowing correctly. So at first they said, okay, we'll teach you how to swallow. That wasn't working very well as his muscles got weaker. And then they said, well, no crackers, nothing that's friable, nothing that's going to break and create crust because you're inhaling those into your lungs. And he was already at risk because he had had 2 lobes of his right lung removed when he had pneumonia. When he first joined the Navy, it was in San Diego for training. He got pneumonia, was in the hospital for 6 months. And they ended up removing 2 lobes of his right lung. So he was already compromised for lung volume. And so eventually they decided that this is just too much hospitalizations and creating too much weakness. And so they put in a tracheotomy, which is an opening in the trachea. Usually what they do is they cut the third, they open up the space of the thyroid gland and cut the 3rd, 4th, and 5th tracheal cartilages and insert a tracheal tube, tracheostomy tube, that typically has a separate balloon type structure around it, like a donut, that they will fill up with air or sometimes saline, but you don't want it to rupture and let that water run it down into your lungs. And that cuff kind of holds it in place. And then the air has to pass out here. Obviously, you wouldn't be able to talk unless you covered that up, and then some of them will be situated so they have another way for the air to get up to your larynx. So this is going to be below the larynx, all right? Because of the presence of the thyroid gland over this region of the trachea, that's an endocrine organ, so it has a lot of blood vessels, and it has to be done in an OR so that the blood vessels can be tied off or cauterized. And this is not where you want to do an emergency tracheotomy, because you wouldn't have the ability to just have blood pouring into the trachea. Also, if you had a sharp instrument like a penknife that you wanted to stab through to open up, the trachea is not cartilaginous. It's closed by connective tissue and muscle on its posterior aspect, but that knife or sharp pin or whatever is going to go right through the back of it, okay? So if you're doing an emergency cricothyroidectomy, you're going to do it in this space between the thyroid cartilage and the cricoid, hence cricothyroidectomy. So you can feel on yourself. In fact, when I went to the coroner's office, the instructor for the paramedics was instructing them how to do it and actually did it on the cadaver. And so you would lift up kind of a space on the neck, you take your finger, drop it down, you'll feel a gap from the thyroid cartilage, the larger piece of thyroid cartilage, you'll feel a small gap, a little bit less than finger width. And that's where you want to go, okay? Now they actually had a cannula, a sharp cannula they would insert in and then pull out the hard plastic to leave a hollow space. And that hollow space was about the diameter of a coffee straw, not a regular straw. And they would attach it to an oxygen tank. That's under pressure. You don't, especially on a child, you don't want to let that much air in at once so that it's guesswork. It's a thumb control. You would just let in enough and then close it off, because if you let it all in, you're just going to rupture the lungs. If you do this, let's say you're in Costco, you know how they pass out the food samples and stuff, and they're supposed to ask permission. But let's say that your back was turned and your kid reached out and just grabbed one on their own. Those little half-inch hot dog things that just fit perfectly into their airway. Most food is trapped within the vocal ligaments, okay, or most objects that are inhaled are trapped within the vocal ligaments. So opening up above the vocal ligaments between the thyroid and hyoid, so up here, isn't going to do much good if the blockage is in the middle of the larynx. So you want to go at least below the vocal ligaments. And so notice what the cricoid cartilage has. If we go between the thyroid and cricoid, if we go too far, you're going to hit the back of the cricoid cartilage. That's going to blunt. You're not going to go through the other side. So that's another advantage other than the lack of vascular structures in that region to going in that area. So a very sharp pencil or knife blade can go in there and then just take like a pin where you can take the ink cylinder out, put it in there and blow through it, because you probably won't have an air tank available. And you'd have to adjust, of course, the pressure. You'd want to feel the chest rising. A few years ago, probably 12, 13 years ago, there was a drowning incident in Roseville, in Raging Waters area, and the girl had had a spasm. The lifeguard saw it happen, so she was out of the water in less than a minute. The ambulance was there in less than 3 or 4 minutes, and they weren't able, because of the spasm of her vocal muscles, they weren't able to get an endotracheal tube past that spasming muscle. That's the perfect indication for a cricothyroidectomy. Paramedics have the legal opportunity to do that, EMTs do not. So there may have not been any paramedics on the ambulance because they did not do a cricothyroidectomy, and she passed away. Because when I read about it in the paper, I was just, well, why did they do this? So I always tell my students about that and show them where to do it. No one's ever written back and say, hey, I saved somebody's life. But it was really interesting to see the paramedics being shown how to do that on the cadaver at the coroner's office. Because they were all EMTs, and they were being further trained to become paramedics. So if you get a question on a lab or lecture material, it's not the trachea, it's not the thyroid ligament, it's the cricothyroid. That's the best site for emergency. Again, because you're below the level of the vocal ligament, but you're not in the vascular tissue of the thyroid gland itself.
So you go through the cricothyroid or right above it?
You go through, well, not the cricothyroid ligament.
Ligament, okay.
You go through the ligament between cricocartilage and thyroid cartilage.
Oh, that would be so painful.
So in our model of you'd be going in right here, or on either side. All right, so let's look at a cross-section of the trachea. And we have 3 different things that we're going to look at. We're going to look at the presence, or as we go through these airways, we're going to look at the presence or absence of cartilage, the presence or absence and location of smooth muscle, and the type of epithelium. Right? So trachea and primary bronchi, the first branches, are going to have this appearance. So a C-shaped hyaline cartilage. And on any histology slides I will tell you what the cartilage is. All right? So I will point out on the slide what structure is cartilage. And then you'll have to figure out, because it's there or not, what the airway is. So it's open posteriorly. There is smooth muscle present, and it is closing that posterior aspect. So here's the C-shaped cartilage. It's actually continuous. And then we have this band, the smooth muscle, that extends all the way along the aspect. Now this model is incorrect. It shows vertical lines. However, the smooth muscle is going horizontally. Okay? And it connects these 2 ends of cartilage. Not all the way around the entire trachea. And this is one of the rare occasions where we give smooth muscle a name. and it's known as the trachealis. Okay? Don't forget to include the IS. Don't just call it trachea, it's trachealis. Trachea is the airway. And then the epithelium, I should do that in a different color, is the pseudostratified columnar epithelium. Cilia. And goblet cells. Okay, with the mucus to produce, to move the goblet cells along. What would this structure be right here?
Oh, esophagus?
Pardon? Esophagus. All right. So in this view, because the esophagus is there, the esophagus doesn't branch. It goes all the way through the diaphragm down to the stomach. So with this view, you know this is the trachea. All right. Without the esophagus there, you wouldn't know if it was trachea or primary bronchus. So trachea here, esophagus here. So if you look on this model, see how that same pattern of a C-shaped cartilage extends along the primary bronchi? So a section through that would look very similar to a section through the trachea. Okay? Now before we move, on our sheet plug dissection on Tuesday, you can feel that soft area of the trachealis muscle. And the purpose for that is to allow, as a bolus of food moves through the esophagus under peristalsis, it allows it to bulge into and part of that trachea to give way. If you've ever swallowed a horse pill or something that got stuck in the area, every time you swallowed you felt this little bump kind of thing, that's the way it would feel every time you swallowed food if we had cartilage all the way around, because that's not going to give very well. Let's go back up to a model of the cartilage. And the right bronchus is shorter and a little bit wider. And also slightly, it's not horizontal, but slightly more horizontal than the left side. So in that pattern, when you inhale something, kids inhale stuff all the time. So it's going to get trapped in that area. Also, when we have a respiratory, we look at this, the trachea, this little keel-like structure that's formed where the two divide is known as the carina. So it's just that ridge of cartilage in the midline that kind of separates the airway one direction to the other. So we get past the primary bronchi, and we move into secondary and tertiary. So can I erase the board? Took a lot of room for that. I'll try to put the others up all in sequence.
Is it anterior view?
As a cross section. So this would just be the front. So our smooth muscle, our trachealis, is on the posterior aspect of the trachea. All right, so here we would have the left primary bronchus, and then going into the lobes of the left lung, we would have the secondary. All right? There's 2 lobes in the left lung, 3 in the right. So we have that number of secondary bronchi. You'll see in the sheet that actually secondary bronchi will come off of the primary. You'll see little openings, but they're not really named. So let's look at those characteristics. Again, remember, we're looking at cartilage, muscle, and epithelial type. So tertiary and primary bronchi are going to be characterized with C-shaped cartilage, Smooth muscle posteriorly. And pseudostratified columnar epithelium. All right, as we look at the, my cartilage glue in that one?
Yes.
Thank you. So as we look at secondary and tertiary bronchi, cartilage is still present. That's a characteristic of trachea and bronchi. When we get into bronchioles, cartilage will be absent, right? However, in the case of these structures, the cartilage is in plates, but it's continuous all the way around the airway. So it's not one complete ring, but the plates, it's a discontinuous ring, if that makes sense. So discontinuous. Ring of cartilage. It's still hyaline cartilage. And we have, well, that's the bronchiole. Well, let's look at a diagram of a bronchus. So here's the cartilage up here. And then the smooth muscle is a complete ring just inside the cartilage. So this is a complete ring of smooth muscle. And then our characteristic epithelium is simple columnar. The primary bronchi, remember, are pseudostratified. And even the first portion of the secondary are going to be pseudostratified. But the characteristic is going to eventually become simple columnar. And then it's going to transition to the simple cuboidal for the bronchioles. But the characteristic epithelium is simple columnar with goblet cells and cilia. Because of the cartilage that's present, even with the smooth muscle there, it's not going to do much to change the diameter of the airway. So even when the smooth muscle constricts, the cartilage is going to keep that airway patent and open. So in an image like this, I would identify the cartilage for you if I was asking for the airway. To identify this airway, I would put a little line in here saying cartilage. The fact that it's in pieces, all right, and not and all the way around rather than C-shape is your clue that it is columnar. I'm sorry, that it's bronchus. So this is what we're looking at here. We start to show the pieces, even more so in the tertiary. So all of these are bronchi. As long as there is cartilage present, it's a bronchus. Okay, bronchus being single and bronchi being plural. Now we lose the cartilage, and we enter a structure known as a bronchiole. So our typical bronchiole has no cartilage. We still have the ring of smooth muscle. We draw this slightly larger. And while the early bronchioles may have some simple columnar epithelia, the typical characteristic epithelia is simple cuboidal. Ciliated, but no goblet cells, because those are columnar.